Hello, everybody, and welcome. I see folks starting to join in large numbers. Going to give this just a moment. How exciting. Thank you all so much, and welcome to Ending HIV in Montgomery County. A very short conversation for a very big topic that we have a lot to say about today. Welcome to our community partners, to our council members and their teams. Welcome to our panelists. I hope everyone is having a wonderful Tuesday. We're going to get started in exactly a minute from now, out of respect for the brief amount of time that we have everybody today. So great to see so many Montgomery County HHS folks on this call. Thank you so much for joining. We're so excited to share this information with you all. And to our community partners doing amazing HIV work in Montgomery County, welcome to you as well. As we're getting started, I just want to say, hey, DC DOH, Hosta, thanks for joining us. Just want to say that we're going to have an opportunity to do Q&A with our panelists today, and we'll be using the Q&A function for that. You're welcome to use the chat function to talk amongst yourselves or to expand on any of the topics we're talking about, but we will be monitoring the Q&A for questions for our panelists. And if we don't get anything in person today that you wanted to ask, we're happy to follow up in writing as well. All right. I think it's probably safe to get started. And I want to thank everyone again for joining us. My name is Emily Brown. I use she, her pronouns. I am the Ending the HIV Epidemic program manager for Montgomery County. I am new to the county. I just arrived here in September from Atlanta. So so excited to be able to share this work with you all in the community and to be a part of this amazing process and this team for so many reasons, because we have so much to talk about today. I'm just going to do a quick introduction of our panelists today because they have a lot to say as well. And they're going to have a lot of time to talk because I'm going to keep my piece really short. But I want to introduce you to our team because I think they make up a really good cross-section of experts in this area and in Montgomery County. First, Dr. Travis Gails. Hi, thank you so much. Our health officer here at Montgomery County and our chief of public health services, someone who has both a PhD and a medical degree and has approached HIV from a really holistic, more than medical perspective for all of his career, who we're really honored to have here leading our HIV efforts and of course our COVID efforts. So we'll talk a little bit about that, but thank you so much, Dr. Gails. That means so much to our whole team that someone who cares so much about HIV is at the helm of this work. And next, I'd like to introduce Melvin Cawthon, who is the lead of our HIV STI programming here at Dennis Avenue Health Center and for Montgomery County DHHS. Melvin leads all HIV STI efforts. Here at the county, he manages our team of 40, has a long history of work in the field directly with people living with HIV as a social worker by trade, and still does direct service work even in his leadership role, which is amazing and super refreshing. So an honor to work with you, Melvin. I want to introduce Ronald Johnson, who is with the LGBTQ Democrats of Montgomery County, but also has a long history of working in HIV advocacy at the policy level through his work as in a leadership role at AIDS United, through the US People Living with HIV Caucus, and various other roles. Really someone who gets the full picture of HIV activism that has brought us to this point in history. So thank you, Ronald. It's amazing to have you here in Montgomery County. And last but not least, Conor Hegel from SMILE, that's supporting and mentoring youth advocates and leaders, and MoCo Reconnect as the LGBTQ outreach coordinator. Conor has a ton of experience with working directly with LGBTQ youth in a variety of capacities, not just in the MoCo area, but nationally, and has a ton of expertise to share in that area. So thank you, Conor, for joining us. We're going to talk a lot about intersections with your work today, and I couldn't be happier. So gonna take a deep breath, and I think something that's been hitting me all day and every World AIDS Day is just why we're here, and the gravity of the fact that almost 40 years into this epidemic, into this pandemic, this global pandemic that is HIV/AIDS, we are still talking about what we can do to make it go away, to stop the enormous human toll that this pandemic and other pandemics have taken. So I want to take a moment and reflect, because a World AIDS Day tradition is to speak the names of people, of individual people that we have lost and cared for because of this pandemic. If anyone feels compelled or interested, you're welcome to use the chat function to type names of folks that you've lost, that you loved, that you cared for, who've meant a lot to you. This year in particular, it's just important as we talk about data to remember the human cost of all of this. And I know that for everyone on this panel and so many of you who are attending, the human cost is very personal. So I've invited Melvin Cawthon here to just read a quick excerpt of a really amazing and powerful poem by Essex Hemphill that he wrote in the early 90s after the death of his friend, Joseph Beam, both of whom were Black HIV advocates, activists, and writers who were doing really impactful writing about the Black gay experience during the early days of the epidemic. And this is an excerpt from When My Brother Fell from his book Ceremonies from 1992.
When I stand on the front lines, now cussing the lack of truth, the absence of willful change and strategic coalitions, I realize sewing quilts will not bring you back nor save us. It's too soon to make monuments for all we are losing, for the lack of truth as to why we're dying, who wants us dead. What purpose does it serve? When my brother fell, I picked up his weapons. I didn't question whether I could aim or be as precise as he. A needle and thread were not among his things I found.
Thank you so much, Melvin. And just going to take a moment to shift gears and to recognize the just the gravity of this moment for all that healthcare logistics happen around this time. The work of Dr. Gails, the work of all of our panelists. There's just a lot of heavy stuff happening right now, and I always say that the world would be a very different place if Essex Hemphill were here and if Joseph Beam were here, still making this beautiful work. So thank you so much, Melvin. And I don't want to overemphasize data at all today. I don't want us to look at these numbers and think that this is a problem to solve with numbers, because that human angle is pervasive and should sort of be a benchmark to everything we do. But the reality of our epidemic in the United States today, with 1.2 million people living with HIV across the US, is that it is characterized, just like it has been since the very beginning, by enormous disparities, racial disparities, ethnic disparities, disparities based on sexual orientation, gender identity. And in fact, the very data itself is not necessarily reflective of the kind of justice we would like to see in defining the epidemic, right? So for example, when we talk about who's at risk, so Black, gay, bisexual, same gender loving, and other men who have sex with men, and Hispanic and Latino, gay and bisexual men, and other men who have sex with men are dramatically disproportionately at risk. And there's huge racial disparities among women, women assigned at birth who are contracting HIV and who have been contracting HIV since the beginning of the epidemic. And so, I think that the other point is that there are the LGBTQ community is disproportionately impacted, but there's very little data and a growing need for data on the transgender and gender nonconforming folks, who may have gotten lost in the mix in a lot of this data collection, but who are, by all accounts and by much research, very disproportionately impacted by HIV as well. So there are racial disparities, there are geographic disparities. The South is very very much impacted by HIV, and although it's declining, HIV as a pandemic is declining in the general population, we see these concentrations happening, and we and the federal government, in recognition that we are not getting close to ending the epidemic, even though we're responding to it and it's slowly declining, we're not quite getting there. So so ending the HIV epidemic is a federal initiative that responds to that says enough is enough. We need to infuse resources into places where HIV is still happening at very high rates. Places like Montgomery County that are dramatically disproportionately impacted versus the rest of the US. Our partners in DC, our partners in Prince George's County, in Baltimore City, and in many other areas around the US are developing their own plans to end the HIV epidemic, to reduce new infections by 90% in 10 years. It's no small feat, but this was intended to infuse resources into that project. HIV in Montgomery County is like our national epidemic, characterized by major disparities. And as we deepen our understanding of HIV in Montgomery County, and as we move forward next year doing more events like this to talk about different aspects of our epidemic and different communities that are disproportionately impacted, we want to make sure that we keep this at the core of our analysis and our approach. So again, we're not going to end this HIV epidemic or any other epidemic for everyone if we don't, for anyone if we don't end it for everyone. So that's the nature of epidemics, right? So there are about 4,000 people living with HIV in Montgomery County, and about 87% of those have actually received an HIV diagnosis. So there are 546 people in our county living with HIV who haven't been diagnosed, who don't know their status. And of 135 who were diagnosed last year, keeping in mind that about 20% of Montgomery County is Black or African American, 62% were Black or African American. So we have, again, a marked racial disparity in who's contracting HIV. And it's worth noting at this point that racial disparities in HIV, for example, between white gay and bisexual men and Black gay and bisexual men, are not attributable to differences in risk behavior. So we're talking about structural inequality. We're talking about access to housing, access to healthcare, access to food, and segregation in sexual networks, not differences in risk behavior. So we see that our epidemic is, again, closely aligned with all of the other epidemics in our region, and shows disparities. And that's something that we are keeping in mind as we're developing our plan. There's so much more data on this. It's in such a granular form through the state of Maryland. When I send out our recap for this presentation, I will send you all links to that data so that you can get more familiar with it. But it's just, I think if you walk away with nothing else, thinking of the structural inequalities that lead to the racial and ethnic and sexual orientation, gender identity, health disparities, that's the most important thing to know. So we were asked to develop a plan to end HIV, which is a daunting thing to do and a daunting thing to think about, especially in the context of another epidemic that is also characterized by major disparities, economic and racial and ethnic disparities. And we wanted to make sure that we develop something that's in line with our values. So we assembled a group of community partners, many of whom are on this in this meeting today, to develop a plan. And our vision is a place where HIV diagnoses in Montgomery County are rare, where if someone contracts HIV, they're diagnosed early, and where we are able to wrap them in the resources that they need to stay healthy, to live a long life, to thrive, and to prevent transmission to others. Our values are transparency and cooperation. We want to work with our community partners to make sure that we are giving everybody in our community a chance to thrive with HIV, that we're person-centered, that we know that people living with HIV and people at risk for HIV are dealing with a lot of other stuff too, that HIV is just one part of their lives. And that we always want to have this bedrock of understanding that if we don't work against the tide of injustice and the tide of inequity, we're not going to make any motion toward ending this epidemic. So super committed to that. Our partners have been fantastic in drafting this plan. You all will have access to the community-facing version of this plan after this call. Very excited about it. Thank you all for your help in drafting it. The plan does follow 4 pillars that the CDC, that HRSA is trying to really hone in on to make sure that we have a holistic approach to ending the epidemic. So the plan aims to diagnose all people living with HIV as early as possible. Again, people who don't know that they're living with HIV can't get the help they need. They can't get to a point where they're not getting sick and where they're not able to transmit the virus to others. Treat people living with HIV as soon as possible and as effectively as possible to reach viral suppression, and to prevent new HIV transmissions using science. And of course, lastly, just to make sure that we're focusing our public health approach to respond to outbreaks. It's a big deal. So this is our plan in one PowerPoint slide, but I want everyone to take the time to review it if possible, following this meeting, and please share with your networks as well, because we want feedback on this. We've spent a lot of time talking to some amazing subject matter experts and people living with HIV in the field in Montgomery County, and these are our broad areas of work. So if our goal in the diagnosis pillar is to diagnose 95% of people living with HIV so that they know their status and they can get the help they need. We really need our healthcare providers in Montgomery County to get on board with routine opt-out screening, so that everybody has a chance when they go to the doctor, whether they know to request it or not, to get tested for HIV, because the CDC recommended that in 2006. And that's one really effective way to get people who may not be thinking about HIV to know their status and to link them to the care that they need. We also need to scale up our community-based testing initiative. So, a lot of times people are marginalized from healthcare for various reasons. A lot of the folks who are contracting HIV are already marginalized from healthcare. So we need to find other novel ways of getting access to testing to folks as well. We need to one strategy is to make sure that we're being really sensitive about partner notification following an HIV diagnosis. So the public health approach needs to be culturally sensitive, needs to understand the intersections of folks' identities and the language that they're using, meet people where they are. And finally, increasing awareness of testing resources through a campaign. We're very excited through EHE to have the resources to launch a campaign about HIV testing, care, prevention, sexual health and wellness in general, and kind of destigmatize, demystify HIV, get the word out about it to our whole community. And the treatment pillar, if our goal is 95% of people who are diagnosed with HIV are in treatment within a month, within 30 days, which is a long time, and 95% achieving viral suppression. So they have so little virus in any given sample of blood that they they have everything under control, they're feeling good, and they can't transmit the virus to others. We need to establish county-wide protocols for linkage to care. We'll be doing that through a collaborative of folks doing HIV testing in the county. We will use data to care to re-engage people who've fallen out of care for various reasons, because there's so many barriers across the healthcare system, right? We really gotta tighten those processes up. We're going to expand access to services to support all the parts of someone's life that might affect their ability to stay and care for HIV, and build capacity of our county's HIV clinicians. So making sure that we're getting the guidelines from the best practices, from the research, and getting those out to our wonderful frontline clinicians across the board in the county. And then on the prevention side, this is a panacea of policies and healthcare approaches. So 90% reduction in new cases by 2030 is really daunting, but do people have access to the HIV prevention pill, pre-exposure prophylaxis in healthcare settings? Do they have it in community-based settings? Do they have access to post-exposure prophylaxis? When they have a potential exposure, do they know that they have 72 hours to get preventive medication? So lots of work to do with getting the word out about those biomedical approaches. And then, of course, condom access expansion, getting the word out about the importance of LGBTQ inclusion in sex ed, knowing how disproportionately impacted LGBTQ communities are with HIV in our county. Improving sex ed across the board, expanding syringe exchange, syringe services programs, and increasing awareness, again, of the full picture of sexual health services through a campaign. I realize I just went through that really quickly, but this is the backbone of our plan, and you can comment on it online starting today. It's live for World AIDS Day. Here's the link. I'm going to send it to y'all as well. But action items for y'all today, get tested. I know it seems like, this message is everywhere in the DMV, but even if you don't think you're at risk, get tested. If you don't feel like leaving your house right now because of COVID, good. And you can get tested at home for free at freetestathome.com/MC. That's a partnership we have with Maryland and the Virginia Department of Health. However you need to get tested, give us a call. We will find you a way to get tested. I'll just say that. And connect folks to that. Connect folks who need to get a test, who want to get a test, who aren't leaving their home, or who want to come to our offices to a test. Connect folks to care. Anyone who needs HIV care, doesn't matter if you have or what your immigration status is, what your insurance status is. We can help you get connected to care at Dennis Avenue Health Center. Connect folks to PrEP, learn about PrEP. If this is the first time you're learning about PrEP, I will have after this, you want to make a meeting with me to talk about PrEP, or someone on our team, we can have a long conversation about incorporating pre-exposure prophylaxis into your clinical services, and then help us engage with our diverse communities around Montgomery County in making sure that our plan reflects the needs of everyone, so that we're really working against those inequities that we talked about. That is all that I have for our plan. And I want to get into our panel. And I want to thank you all for listening to that. And if it's okay to proceed, I'm going to go ahead and ask Dr. Gails the first question today. So Dr. Gails, you've been at the helm of our COVID-19 crisis since day one, literally, in Montgomery County. And we've talked a lot about racial and ethnic and other health disparities today, characterizing the HIV epidemic. But I would love to hear your thoughts about, why are these disparities happening, and what your vision may be for health equity in the county.
Sure. Well, first, let me say thank you for the opportunity to be here with everyone today. And thank you for all of the work that you all have been doing historically. For, as you mentioned, disparities didn't just show up today. They've been around for years, and the work has been around for years. So thank you to everyone who is a part of the call and your networks for the tremendous work that you have done to get us to this point where we are today, and will undoubtedly continue to do as we move forward. So when we talk about health disparities, it's interesting because for a lot of people, they've just discovered them in terms of COVID. They're fascinated by, oh, well, why does it disproportionately impact certain communities? And we've got to do something. And for a lot of us in public health, we're like, welcome to the party. Where have you been for decades? And I will say this, I think that we have made progress, but we have become experts at renaming health disparities more than actually addressing them. We can call them different names: health disparities, health equity, health inequity, social determinants of health. However you name it, we've repackaged it in many ways, but we've done less of the work in terms of actually creating the type of systemic change to address those issues. I think part of that is because we aren't necessarily asking the right kinds of questions to get the data to inform those kinds of conversations. So for example, Montgomery County, when we were identified as here's an example, we were identified as one of the communities as part of the ending the HIV epidemic. I had a number of folks say, well, that number can't be right, because is that the number of people who test positive in Montgomery County and then go back to their homes? That can't be here. And I'm like, no, this is the picture of Montgomery County. And I think for many years, we've held, at least in this county, we've held the attitude that it's not us, it's an other jurisdiction kind of problem. And that has led to challenges in terms of asking the right kinds of questions to get the data, getting more support for the infrastructure to continue to work on a local basis. But conversely, on a national level, we haven't always been seen as part of as a community of need to support. I think another factor that has contributed to the perpetuation of health disparities is systemic racism, systemic stigma, systemic homophobia, systemic transphobia, systemic injustices across the board that impact who leads our organizations, who determines who gets funding, who has a seat at the table, and coming up with strategies that are rooted in the realities of the communities that we're hoping to help. I think too often we in public health struggle from creating a one-size-fits-all model to address a problem and then getting upset to be like, well, I don't understand why people aren't taking advantage of what we put out. Why aren't they doing it? It must be their fault. As opposed to being more reflexive and saying, how can we take what we have, ground it within a community sense of the communities we're hoping to help, empower those communities to have leadership in making the decisions that are impacting their communities, so that the end result or the end goal of the product that we put out is grounded in those realities and is actually focused on the different parameters that are impacting folks' daily lives, that are going to remove those obstacles to increase their adherence, increase their linkage to care, and increase their connection to the supportive services that are in place to help them out.
Thank you so much. And you know, thanks again. I know there's a lot going on with COVID, and we're really lucky to have you here. So thank you. Ronald Johnson, from your perspective, you've been doing this work for such a long time, and people living with HIV activists have really shaped the landscape of care and prevention that we have today. And you are an activist. But from the perspective as someone living with HIV, you know, we talk about HIV being a chronic manageable illness nowadays, and yet so many people living with HIV are out of care and don't have the medication that they need to be healthy, to actually feel like it's kind of a one pill a day thing. What's going on? Why do you think folks are not in care?
Thank you for that question, Emily. And first, I want to underscore how important being with care is, and maintaining continuous care and adherence to medications. But when we look at people who are experiencing lapses in their HIV care or in and out of care, there are, of course, purely individual factors that result in those lapses, but there are some very real structural challenges and barriers that we need to highlight. One is just access to affordable care and the barriers and challenges to accessing affordable care. Insurance issues, and particularly in a time of COVID, when so many people are experiencing unemployment or lapses in that employment. They also may experience lapses in their health care and health coverage. So that could lead to people having lapses in their HIV care. There's also the stigma and discrimination, and both you and Dr. Gails noted the inequities and disparities that exist. If a person does not feel comfortable because of racism, homophobia, transphobia with their health provider or clinic, that could be a factor in their going out of care, experiencing lapses. Also, there are mental health and substance abuse issues that need to be dealt with, and people who are experiencing mental health issues, people who are experiencing alcohol or substance use disorders, they need support that would enable them to stay in healthcare. So other factors, homelessness, all of these factors can contribute to a person who knows they need to stay in care, but don't have the support, can't deal with the barriers. So we shouldn't shame people for having a lapse in care. We need to think about how we can support their staying in care.
Thank you so much. And that's such a good reminder. It's on us, right? And to that point, Melvin, I would love to to hear your thoughts on the kind of experience that you're trying to create as the person, the buck stops with you with regard to HIV services. You know the barriers, you've been working in the field for a long time. How do you create an experience that's really person-centered and that doesn't, like, what do you want someone to experience when they walk into our clinic?
Thank you, Emily. That's a good question. I think it's important that we acknowledge that a lot of our clients are still reporting stigma and shame as things that, as feelings that they're having, things that they worry about. Also, as I'm listening to you and Dr. Gails and Ronald speak, that there are things they're not reporting. They're not reporting the homophobia. They're not reporting the transphobia. They're not reporting the underlying things that might make them fear or certain kind of pause before coming into care. So the experience I would like to have, whether folks are getting care at the health department or with one of our partners, because I think it has to be universal, is that it's not that they feel welcome, that there's an active action going on to make people or help people feel welcome, meaning that it's not enough to say we welcome everyone. I want folks to feel when they walk in the door, yes, they welcome me here. Whatever that means, whether it's, certainly we see a lot of immigrants, so it's whether it's materials in other languages that, that we provide, whether it's staffing that reflect, whether it's in race or diversity, folks experience. So what I would like to see that everyone's experience is when they leave, because that's the most important thing. Yes, we want them to feel comfortable. We want them to feel welcome when they come. We also want, when they leave, that this is a place I want to come back to. Whether I get care here, whether this is a place where I can find out about resources. That is really big. And I think that we stress that, is that, yes, the message when you come in is that we want you in, we want you into care. But I think just as important is when you leave, you felt good that you came and you want to come back.
Thank you. Yeah, thank you so much. And Conor, I talked a lot, and with our panelists, I've talked a lot about these disparities and that they're not attributable to behavioral differences. And when we look at the data at a more granular level across the US, LGBTQ youth of color show up as a real priority. But it's really, I think, hard to contextualize. I guess my question for you is, what's going on in the lives of LGBTQ youth that you've worked with, and where does HIV fit into that picture for them?
I mean, I think a lot of that can be regional. Like when I was working in New York City, especially amongst homeless service providers and homeless LGBTQ youth, like there were condoms, on everybody's desks and everywhere, and everybody was getting referred to testing and stuff like that. But if even here in Montgomery County, I know that those kinds of things just are not as prevalent. It's just not talked about. There's not LGBTQ inclusive sex education, as you mentioned earlier. There's been a great push at the youth level to start having workshops on healthy relationships and consent, which is fantastic, but they're also not LGBTQ inclusive. So when you think about the fact that LGBTQ youth are more likely to be bullied, they face possible rejection by their family and friends, higher risks of depression. You have, folks with lower self-esteem who have been given no tools to advocate for themselves. So they can either go looking for acceptance, which can come from folks who are exploitive or have predatory, intentions, or they just don't know how to talk about their own sexual health needs and what they want. Even if they would want to use a condom, they don't know how to ask for it. They don't know how to insist upon it. And then if you look at, the higher instances of homelessness amongst LGBTQ youth, then you have an entire other, set of problems. Youth engaging in survival sex work, where, they might not be able to have someone wear condoms if they want that place to sleep, or if that person is going to pay them and they need that money to survive. So that will put them at a higher risk. And then also, obviously, homelessness is a huge barrier to care in general, not being able to have consistent access to healthcare, access to prescriptions, like losing medication if you are on PrEP or PEP, possibly, losing it, having it getting stolen from a shelter, things like that. So that, there are a lot of barriers that they're facing. And I think also in ignorance, we don't want to think about kids having sex and possibly getting HIV. And so we don't talk about it. And so if us as adults are not comfortable with this topic, there's no way that we can really impart that wisdom and comfort in young people who need the information in order to keep themselves safe.
Thanks so much, Conor. And I feel like we're going to circle back to that conversation repeatedly over the next 10 years. Yeah, thank you so much. And that came up repeatedly in our conversations with stakeholders as well. We can do more. We can do a lot more. Dr. Gails, to that point, thinking of community leaders outside of healthcare, outside of public health, what is your thought about some ways that people who don't work in healthcare or public health can do something about HIV right now? Maybe our community leaders who have policy influence in the county, for example.
Sure, that's a great question. I realized I left off a piece of the first question that you asked me, and it kind of feeds into this question in terms of our vision of how we want to move forward from a health perspective. I think the biggest thing is recognizing, as all of the panelists have brought up, is there's so many other factors outside of the clinical experience that influences from the prevention side, from the treatment side, and from the linkage to care side. And that is emblematic of all of our public health issues that we're facing. COVID's a great example. And what we're going to have to do is, in order to fully understand the impact of all these systemic things, as well as, however you name them, social determinants of health, it will require a nimble and flexible approach. Now, one of the approaches that we have adopted to address our health conditions in Montgomery County is the health in all policies approach, which basically says we recognize that there are all these factors that influences a health outcome that aren't solely the clinical encounter. And in order to fully address that and understand it, one, we've got to get better data to understand the impact of all of these different things. One that I know comes up in the HIV field a lot is housing stability and access to stable housing. We know that access to stable housing is a big indicator from a prevention standpoint. It's also a big indicator of your ability to be compliant. And so, looking at how we can work with our different agencies across government, as well as out in the community, to address those particular issues. So looking at how we attack housing from a health perspective, being able to, one, get data to demonstrate the impact of stable housing on different health outcomes, whether we're talking about HIV, diabetes, COVID, et cetera. Access to fair, equitable employment that is meaningful and substantive in terms of being able to meet folks' basic economic needs, access to educational opportunities. It reminds me of one of the, when I was back in Chicago practicing, we looked at, the construct was called socioeconomic disconnection. And socioeconomic disconnection was defined as a young person, 16 to 24, who was not in school and not employed. And we found that there was an increased risk for those. It was 16 to 20-year-old young MSM in Chicago. And we found that those who were fit into that category did have increased risk of acquiring HIV. And so, it demonstrates that there's room for the traditional public health messages, but we've got to be more flexible to work with our community partners to explore different ideas. And so, for example, in that instance, when we highlighted this new construct, we said, hey, in addition to what we're doing in terms of testing and screening on our regular stuff, we've got to be talking to our schools and talking to our employment opportunities to talk about vocational training and access to those things, because we knew that could be a significant factor in preventing, as an additional prevention tool. So I say all that together is we've got to do a better job from public health, articulating that message and breaking down the data to explain those impacts, and then utilizing all of the different community networks to amplify that voice. And when they're coming up with policies in all of these different areas that traditionally we don't think about health, we've got to get them to understand the impact of their decisions on health and to start rethinking how they're putting in policy to better help what we're doing in the HIV world.
Thank you. All great points. And we have a question from an attendee about condoms in schools, and just sometimes there's public backlash to initiatives that look at policy change around that. And this person wanted to get your thoughts about what might work to help get more condoms into schools.
Well, I think the biggest thing is you have to rip the Band-Aid off and have the conversations, which is kind of what we did here, and not be afraid to talk about sex. And not only be afraid to talk about sex, but to talk about sex in a healthy, positive way. I think, unfortunately, so much of our messaging, not only to young people, but when we think about how we talk about sex as grown adults, when we go see our doctor, it's always couched in this, did you do something? Do you have a drip drop discharge? Do you need to be treated for something, as opposed to asking about it in a more natural, positive, because that's how we all got here. So I think we've got to reframe how we talk about that. And, condoms is just one piece of that. I think when we are interacting with young people, I think we have to, at least, and this is how I used to practice medicine, from a very sex positive approach in terms of how you talk about that. Making sure that they're safe, it's consensual. They do have access to reproductive types of stuff, whether it's condoms or birth control, those kinds of things. But create a space where it also allows them to lead the conversation. And it's not always us throwing messaging at them, so that we can have a better understanding of what their needs are and meeting them where they are. But then to expand from that is, again, I think we miss opportunities, at least from provider perspective, of we still have a very rigid definition of how we approach sex with older age groups as well, in terms of talking about it in a healthy way. And I think we miss opportunities to provide education to our patients and clients. And we also miss opportunities for them to share with us what they're thinking, or what's going on in their world, to get a better understanding of why they may have missed an appointment, or why they may have missed a dose here or there, or those kinds of things.
Thank you so much for answering that. And yeah, keep the questions coming, everyone. Ronald, little bit of a departure from this conversation. I just, in case it's relevant to anyone on the call, anyone in the meeting, what's a good piece of advice you might have for someone who has a family member or is themselves newly diagnosed with HIV living in Montgomery County, given your experience? Oh, you're on mute. There you go.
Thank you. I think one of the first things is to make sure you are demonstrating care and support. If a person has been newly diagnosed, even in this 40th year of the epidemic, getting a new diagnosis of HIV can be very traumatic, and demonstrating the love, care, and support for a person who discloses to you that they have HIV positive and been diagnosed is very, very critical. And then helping them, getting linked to healthcare, helping them find a healthcare provider, just showing that and demonstrating that ongoing support that you have for the person, a family member, a friend, whoever it may be. I think that is very, very important, to demonstrate that they are not alone, that you're there to provide whatever help they want and whatever help they are able to receive. You're there for them.
Thank you so much. And we have a question from Genevieve. How is Montgomery County Health Department engaging immigrant and foreign-born populations in EHE planning? And I'll just speak really quickly to this and then pass it to Melvin, because I know that we serve in our clinic a lot of folks who were born elsewhere and now live in the US. And I'll say that we have had a great experience working with our county community engagement groups, our African Affairs group, our Caribbean Affairs group. I think we have a couple of folks representing on the call to really make sure that we're getting feedback from everyone who is disproportionately impacted by HIV in the county. But it's something that we realize that makes us in some ways as a county unique, and we need to do more and need to do better with materials translation, outreach directly into communities that are in most need of getting information about HIV. And I'll let Melvin speak about the folks who we serve here at the clinic, if that's all right.
Yes, so Emily, I agree with you 100%. Over 70% of the folks that we see are foreign-born. So this is a very important population for us. In our EHE efforts, we made real strong efforts to make sure that the voices were included. And in care here, we make sure that our staffing is diverse. We make sure that there are languages available. But you're absolutely right. It is critical that we reach out to this population. It's critical that they're involved in this plan. And certainly we see on our day-to-day care that we get to see the needs. But as I was thinking, it's also critical at one part that we talk with folks to identify the need. But it's even more important that folks are aware of the resources available. That's what I find, that there are resources available many times, whether it's for housing, food emergency, those kinds of things, for language, but folks don't always know. And so part of this EHE effort, I think that it is really on us to make sure as we're getting out messaging as far as testing and so forth, that the messaging also about resources, that our partners know about resources. We've reached out to some providers who we kind of do the most work with, to let them know if your clients are reporting they can't get their medication, then let us know that there are resources to assist them. If they lose their insurance, let us know. I think this is going to be as important a part of our effort, is making sure that folks know what's available.
Absolutely, thank you. And again, everything that we're working on now is the result of a ton of decades of hard work on the team's behalf here, but a new infusion of resources and energy through EHE. And so we are really open to novel ways of reaching folks that we've not tried before, and we're hoping to do a lot of really innovative stuff with a lot of people that we haven't engaged with before. So it's something we're pretty humble about, and we realize we have a lot more work to do. So thank you for that comment. We're hoping to learn a lot, for sure. I want to go back to something that you said, Conor, earlier, and thinking about kind of the age spectrum of people that we're talking about, people living with HIV in the county who skew on the older side, and then people who are at risk for contracting HIV right now are on the younger side. Obviously, there's permeability to what I just said, but just wanted to talk a little bit about how your comments about how people kind of we've always kind of done it wrong with young folks. We don't like to talk about sex, and Dr. Gails mentioned this kind of squeamishness as well in healthcare. What do you think works when you're talking to young folks, especially LGBTQ youth who might be accessing other social services? What works when it comes to talking about sex and HIV, and what doesn't?
I mean, I think first and foremost, whoever it is that is talking needs to be absolutely comfortable and knowledgeable, not just like reading slides or reading things off of a script or something like that. They need to be able to actively engage with the young people, with the material, and answer any questions kind of on the fly. Be comfortable enough for those questions with the shock value that are inevitably going to come. Because kids know, they know when we're being sincere, they know when they're not. And if they can sense that whoever the adult is talking to them is embarrassed or shy or secretive or holding back, that just sort of reinforces that sex is something that shouldn't be talked about. So then if they do have unprotected sex, they're not going to tell anyone when they should be, looking for PEP or morning after pill or anything like that. If they're sexually assaulted, they're not going to be as comfortable coming forward because they haven't been taught how to be comfortable talking about sex. When it comes to like actual kind of concrete things, I've always had good responses with anonymous question boxes, you know, for people who don't necessarily want to ask their question out loud. They think it might be stupid, whatever. That's a great way to really get honest questions. Also, like keeping in mind that when you're talking to LGBTQ youth, you're not just talking to like cis gay youth who only have sex with other cis gay youth. A lot of times you might have trans individuals, you might have lesbians. So if all you're talking about is condoms, you're leaving out a large proportion of young folks and a lot of different types of sex and preventative measures. So including, you know, gloves, dental dams, talking about internal condom usage, just kind of covering the whole gamut. Because knowledge is key. And even if it's not necessarily the highest risk type of sex for HIV, even getting, you know, smaller infections is something that's not going to help, you know, overall HIV transmission rates at all. And giving folks this knowledge and having them able to understand what their actual risks are and know what they should be doing will help them advocate for themselves and kind of feel seen. You know, they want to be talked to like an adult. They don't want to be talked down to, or, you know, have like silly little pictures or something like that. You know, they want to see it, you know, demonstrating how you actually put the condom on. You know, I had a coworker who used to demonstrate internal condoms using a bagel, and that was always a really, you know, I mean, you want to talk about keeping kids engaged, those are the kind of things that's actually going to get folks to actually pay attention. So yeah, just kind of being real and making sure that you're playing to your audience.
Thank you so much for that. And again, I want to say, you know, we have so many more conversations to have in the coming years about this. I'm very excited about your work and your engagement on this. So thanks, Conor, for that. Dr. Gails, just so we cover this, I mean, from your medical perspective, what could a person diagnosed with HIV today in the US, in Montgomery County, expect to experience medically?
Well, fortunately, with the great advancements we've had in terms of not only the quality of medical treatments we have available, all of the different regimens that are out there, but the method of delivery, you know, we've got much, you know, simplified regimens that, you know, combine things into one pill or just two pills, or now we've got injectables that would, you know, change the way we think about adherence. And, you know, be able to, you know, negate a lot of that, you know, taking a pill every day, but still being able to get the benefit. So, you know, there are clearly obstacles, and there's certainly issues and trauma associated with the diagnosis. But from a medical standpoint, there's so many different options available that, you know, what I used to tell my newly diagnosed patients going back to Chicago, can you tell I miss Chicago a little bit? This practice probably more than miss Chicago, but at any rate, is that your life trajectory will not change, you know, if you're compliant with your medication, and you're going to still be able to pursue everything that you thought about pursuing in terms of professional goals or personal goals. And, you know, there's hope that the medications will get even better, you know, with the potential advent of treatment to cure, where we may be able to get to a level where folks have a functional cure that takes away the need to take a medication every day. Now, we're not there yet, but, you know, there's so much promise in that area, which is drastically different from where we were 5 years ago, 10 years ago, and certainly, you know, from the early stages of the pandemic, or the epidemic, I'm sorry.
Thank you. Thank you so much. Yeah, I feel like so it's such a hopeful moment biomedically, right? And so our job is to really get behind this equity conversation, and to an extent, we'll see that becoming true with COVID. And so appreciate all the questions about that. Melvin, to cap us off today, EHE, Ending the HIV Epidemic as an initiative, requires us to go beyond people who have HIV in their job title and to talk to folks who are doing social services work, healthcare work that doesn't necessarily yet include HIV. What's something that folks who fall into that bucket, who might be on this call today, what's something they can do like tomorrow morning when they wake up to start incorporating HIV into their work?
That's another good question. I think that one of the things that hopefully this is laying the seed for is that that we're opening up and hopefully making it possible for an HIV conversation to be more comfortable, that inviting an HIV dialogue into certainly whether it's social services, whether it's food stamps, whether it's whatever kind of the angle is that we're not uncomfortable or getting to that place, that next step, we're not uncomfortable having a conversation that involves HIV, certainly that involves testing. And maybe that's the easier conversation to have. Certainly as our messaging gets out, the hope is there's going to be more messaging about testing, there's more messaging about resources. And so whether it's a conversation that is initiated or a conversation that this person will respond to, meaning that maybe the best thing that I can do starting tomorrow is any avenue or any opportunity that I have to participate in a conversation surrounding HIV, whether it's about testing, whether it's about resource, whether it's about messaging, I'm going to take the opportunity. I'm not going to let it fall by the wayside. I'm not going to pretend I didn't hear it. That if I hear, if I'm participating in an HIV conversation, that I will participate in it. Hey, that's right. On that call, the webinar, that's right. We talked about HIV. We talked about testing. We talked about testing in the county. Is that we become more comfortable participating in conversations like this. That for me probably would be the first step. So tomorrow is that making that commitment, not just shy away from conversations like this, maybe making that commitment of getting a little more information, maybe being on the outlook for the messaging that's coming about testing, about resources, about care and treatment.
Excellent. Thank you so much. And I want to say thank you again to all of our panelists. And we are going to be doing a series of webinars coming in 2021. We may actually, I did see that comment, the question about COVID and HIV. COVID has definitely impacted HIV testing rates, HIV care engagement, and we have a lot more to say about that than we can say in the last 2 minutes of this meeting, but we may be, stay tuned, scheduling a similar event to talk specifically about that, because we need to come up with ways to allow folks to get tested during COVID precautions, such as getting tested at home. And thank you all for the folks who were fixing the link for me. And I really wanted to encourage folks to check out our plan, to share it with folks. We can take your constructive criticism. We want to do more. We want to do better. We want to thank our county council this morning for their World AIDS Day proclamation, which really just was a fantastic World AIDS Day surprise. And I think this is a wonderful time to live in Montgomery County if you care about HIV, because clearly we have some fantastic leadership here and some people who are having the hard conversations about what we need to do over the next 10 years to get way past 90%, but to make sure that health equity is here for everyone, and that the next pandemic doesn't have that opportunity, right? So I want to say thank you again to all attendees. We will, some of us, be staying on. I will be staying on as a buffer at the end if anyone wants to ask questions about the program or the or EHE. And again, I appreciate y'all's time. Thank you so much, Dr. Gails. Thank you so much, Melvin, Conor, and Ronald. And thank you to our partners at Link for helping us administer this meeting. Have a great day.